All right, the recording is on, and in the chat window, open up the chat window, and if you're here, type your name in there. Time for roll call. While you're doing that, the test for chapters 13 and 15 is going to be on May 8th. Okay, the college semester ends on May 15th. So we need to take care of everything before the 15th. So for these two chapters, chapter 13 and 15, the test will be on May 8th. Also, what I'd like you to do right now is in your browser, open a tab, go to your browser, open a tab, go to Canvas, and log into Canvas. Okay, in Canvas, there's the different modules for this class. And for this module, there's a video. Okay, so I'm going to kind of point to what I'm looking at right now. So I'm going to share the screen for a second. And what we should be seeing is under the chapter 13 module, there's a video that says Jerusalem syndrome. So I'm going to reference that later. So right now, I just want to make sure you see where it is and know that you can click on that to open that up. Okay, so we're back here. All right, before I get going with the lecture today, does anybody have any questions before I get going? Okay, if you have any questions along the way, make sure you unmute your mic, because once I share the screen, I can't see the chat window. I'm not able to have them both open at the same time. All right, today we're looking at mood disorders. Okay, mood disorders are extreme disturbances in emotional state. And so there's two main mood disorders. Now, we all feel down sometimes, especially if you break up with your boyfriend or girlfriend, you break up with somebody, or at a time in your life when you experience the death of a loved one. Okay, at some point we all feel down, but people with major depressive disorder experience a lasting and continually depressed mood. There may not always be a clear trigger to that. Clinically depressed people can be so sad that they may have trouble sleeping, or they may sleep a lot. When people are experiencing distress, one way to escape from distress is to sleep. And so they may sleep a lot, but sometimes people are distressed, and so they're thinking about things and they can't get to sleep. So it can kind of go either way. People who are suffering from depression may have a hard time concentrating, thinking clearly, recognizing their own problems. They might feel guilty, they might contemplate suicide. So sometimes we can be aware of those kinds of things. If we see a student who's been a good student and now they begin to have problems concentrating in class, if they've had friends but now they're withdrawing from their friends, not seeing their friends as much, not finding enjoyment in the things that they used to enjoy, those are all indications of depression. And so we want to be aware of those kinds of things when they happen, because we want to be able to get people help, because depression is a very treatable disorder. Another major mood disorder is bipolar disorder. With bipolar disorder, there's these episodes of mania and episodes of depression. During a manic episode, the person might be overexcited. They might be easily distracted. They exhibit an unrealistically high self-esteem and an inflated sense of importance. And during this episode, often they exhibit poor judgment. So they might give away valuable possessions during a manic episode, or they might go on some wild spending spree. And so that's very common for people in a manic episode to be spending lots of money and buying things. And then later, when they come out of the manic episode, looking at all of this and saying, what am I doing with all of this stuff? Sometimes a person may be angry during a manic episode. So a manic episode could last a few days, it could last a few months, but generally it ends abruptly, and then the ensuing depressive episode lasts about 3 times as long as the manic episode. And during the depressive episode, people exhibit the same symptoms of some depression. All right, so when we look at these two graphs, they're kind of representing the difference between major depressive disorder and bipolar disorder. We can see that if the dotted line represents basically what a normal mood level would be, people with major depressive disorder spend most of their time in that more depressed state. Now, sometimes they're way depressed, sometimes a little depressed, sometimes normal, okay? But most of the time they're in a more depressed state, whereas people with bipolar disorder spend some time in the manic state where they're really elated and excitable and distractible, and then they spend time in the depressed state, so they can go back and forth. What are some causes for mood disorders? A big cause is biological reasoning, the brain functioning, but really the neurotransmitter imbalances. Things such as serotonin or norepinephrine or dopamine, even iron deficiency. People have iron anemia, can be in a depressed state because of the imbalance of the iron in their system. And so drugs can help restore these normal levels of neurotransmitters, which makes that very treatable. And because these drugs that restore these levels of transmitters tend to bring people out of the depression and are able to function normally, then they're called antidepressants. So we understand that an antidepressant is not saying, okay, the person is depressed, we're going to give them a stimulant. That's not what an antidepressant is. An antidepressant is working to restore the normal levels of these hormones and neurotransmitters. So then a person begins to function normally and have normal mood levels. Now, one thing with when people are taking these antidepressants, sometimes what happens is they're taking the antidepressants and then they feel okay. They're saying, okay, I'm not depressed anymore, everything's good, and they stop taking the drug. But the thing is, it was the drug, the antidepressant, that was helping maintain those levels. So when they stop taking it, then those levels get out of balance again, and they get into a depressed mood again. So it's important for people who are using antidepressants to continue to use them, or at least to work with their doctor on weaning them off of those drugs if possible. Sometimes people are depressed because they're not getting enough sleep. There's other things going in their life causing maybe some anxiety, And so they're thinking about this, they're not getting enough sleep. And when we don't get enough sleep, then our mood can be altered. So sometimes it's just a matter of giving somebody to help them relax in the evening, and then they can get to sleep, have a good night's sleep, and then their mood returns to normal. Genetics can be a factor, that there's a predisposition, and then things can work with that in order to develop depression in somebody. Evolution is always thrown out. Bipolar disorder is also something very treatable. Lithium salts is a very common drug to help people with bipolar disorder. There's other drugs that are coming out now that help people to get a balance in their system. And so then they can function with normal mood levels. Okay, we're going to take a little test now. Oh, forgot the other reasons for explaining mood disorders. Psychosocial, obviously, there's environmental stressors. Things happen in people's lives, and it causes them to be distressed. They may have interpersonal relationships that get disturbed and have problems with that causes them to be depressed. Sometimes it's faulty thinking, and so that's something very treatable in therapy, that we can get people to realize how they're thinking about things and how to readjust their thinking. Sometimes people have poor self-concept. We talked before about learned helplessness. So sometimes people have tried to make changes, and whatever they've tried hasn't worked. And so then they begin to feel hopeless, that nothing they do matters. And they have this feeling of helplessness, and so they stop trying. And then, of course, they become depressed. And then faulty attributions, what they attribute their success or the good and bad things in their life to. Sometimes the faulty attributions can cause people to be depressed. Okay, on a little piece of paper, write down your answers, true or false. Usually in a classroom situation, I have people raise their hands, but right now just do true or false, and then we'll see how you do on the test. We'll come back to the answers. Number one, suicide usually occurs with little or no warning. True or false? Number two, only depressed people commit suicide. True or false? Number three, thinking about suicide is rare. Number four, suicidal people are fully intent on dying. Number five, people who talk about suicide are not likely to commit suicide. Number six, suicidal people remain so forever. Number seven, men are more likely than women to actually kill themselves by suicide. Number eight, when a suicidal person has been severely depressed and seems to be snapping out of it, the danger of suicide decreases substantially. And number nine, asking a depressed person about suicide will push him or her over the edge and cause a suicidal act. Now in the classroom, usually when I'm having people raise their hand or just say their answers, some of these, there's a lot of agreement, and some of these we see that some people are saying true and some people are saying false. Okay, first of all, suicide usually occurs with little or no warning. That's false. Most people send overt or covert signals. The problem is in a family, the way people think, there's no way they could comprehend in their mind that their family member could even think about suicide. And so while the warning signs might be there, they just don't have a mindset that that's even possible that they could do that. And so afterwards, sometimes they look back and say, oh, well, they did this or they did that. But at the time, it's hard to believe that your family member could do something like that. It's like your mind cannot comprehend that, and you just don't believe it. And so it's often that people miss those signals. In my daughter's case, she began cutting herself. And she knew that her friends saw that evidence of her cutting herself, but nobody said anything. And she felt that because they know that's happening and nobody said anything, she felt nobody cared. And then she bought a scalpel and cut her wrist. So fortunately, there were other people in the house at the time, and she was able to get obviously the medical help at the moment because it was pretty serious, but also she was able then to get the mental health help after that. So it's difficult to comprehend, but we need to be aware when people are saying things or writing things or doing things, that we need to pay attention to those signs. Number 2, only depressed people commit suicide. Okay, that's false. There's all kinds of reasons why people commit suicide and all kinds of factors. So it's not just depressed people that attempt suicide. Thinking about suicide is rare. That's false. Almost everyone at some point in their life thinks about it in some way. Sometimes people get to a point where it's just they think about it, maybe not seriously, but thinking about suicide isn't something that rarely happens. Almost everybody at some point at least thinks about it in some way. Suicidal people are fully intent on dying. Okay, that's false. Most people don't want to die. It's just they get into a situation and they feel that the situation that they're in, there is no hope of getting out of it. And they feel this hopelessness, and they don't see any escape from the situation. And they want the pain or the suffering or whatever it is, they want it to stop, but they don't know how. They can't see that there's any way to stop it, and that they want to escape that. So it's not that they want to die, it's just they don't want to keep on living in the way that they're living, and they see no way out. People who talk about suicide are not likely to commit suicide. That's false. We just said a moment ago that people give signals, and one of the signals is sometimes the things that they say, that nobody'd miss me if I was gone, or it'd be better off if I was dead, or if I'm going to kill myself to get out of here, those kind of statements. So most people make some kind of statement and they give those warnings. Suicidal people remain so forever. That's false. Usually people are only suicidal for a limited time. People that can get the correct therapy can often then deal with the depression or the anxiety or whatever it is that was overtaking their life and their thoughts, and they can get the help, and they then aren't suicidal later. Now, some people get stuck in the same situations and they can't escape, and they get put back in the situation. And so some suicidal people are then more prone to a second attempt or a third attempt, that kind of thing. But people generally get the help that they need at that point, and they're not suicidal, after that. Men are more likely than women to actually kill themselves by suicide. Well, we have to understand the difference between what we're talking about here. Women are more likely to attempt suicide, but men are more likely to use a more violent and quick method. And so men are more likely to succeed at their attempt at suicide. So yes, when a man tries to commit suicide, he's more likely to succeed. But women are more likely to attempt suicide. When a suicidal person has been severely depressed and seems to be snapping out of it, the danger of suicide decreases substantially. Well, that's false, because there's a point at which they're so low that they don't have the energy to do something. They just want to lay there. But as they begin to come out of it, okay, that they get to a point where they're still depressed, but they have the energy now to do something. And so now that they have the energy at that point, then they're at a greater risk for attempting suicide. So we have to monitor the progress of somebody who's getting treatment. Asking a depressed person about suicide will push him or her over the edge and actually cause a suicidal act. That's false. People who are thinking about suicide are often withdrawing. They need to know that people care. When people ask them about that, it gives them permission to talk. And so now they feel like there's people that care, that are understanding them. Not talking about that leads them to further isolate themselves, feel that people don't care, and sink into a deeper depression. So it's important then to talk to people about suicide if you think they're contemplating that. And of course, it's important to get people help. So if you notice signs or symptoms, you need to get the people the help that they need. If people are cutting themselves, you can't think, oh, well, if I tell somebody they're cutting themselves and they're going to be mad at me and not be my friend. Well, if they're dead, they're not going to be able to be your friend. You need to save their life and not worry about if they're going to be mad at you or not, and get them the help that they need. All right, so we have two major forms of mood disorder. Who can tell me one of the mood disorders? There's only two. Tell me one. Somebody turn on their mic, give me an answer.
Bipolar disorder?
Yes, bipolar disorder. And then the other one is major depressive disorder. Okay, which one of those is characterized by repeated episodes of mania and depression?
Bipolar disorder?
Yes, obviously bipolar. We have the two extremes. Okay, another kind of mental disorder is schizophrenia. Schizophrenia is considered a psychosis. That means the person is out of touch with reality. And so schizophrenia is a group of psychotic disorders that involves major disturbances in perception, in language, in thought, emotion, and behaviors. So the individual withdraws from people and they withdraw from reality. They often withdraw into this fantasy life that's marked by delusions and hallucinations. So schizophrenia, we have that separating from reality, and this is where delusions and hallucinations occur. Okay. Media often gives wrong portrayals of things. And so in the media, they often portray somebody as having multiple personalities, and so they're saying they have schizophrenia. And that's not true. Schizophrenia does not involve multiple personalities. We'll get to the disorder that involves those shortly. But we need to understand multiple personalities is not a form of schizophrenia. All right, so there's several major areas of disturbance. The first is perception. So this is where people have hallucinations. They see things that aren't there. So visual hallucinations is seeing things that aren't really there. Auditory hallucinations are the most common for people with schizophrenia. Visual hallucinations can occur, but auditory hallucinations are very common. So they're hearing voices in their head. They're hearing people tell them to do things or just making comments to them. And then another portrayal about people with schizophrenia is that they're dangerous to other people. People with schizophrenia are more likely to be self-destructive than violent towards others because they're hearing these voices and want them to stop. So, they may do all kinds of self-harm to try to get rid of these things. All right, another major disturbance is in language. So often people that are suffering from schizophrenia, the words lose their meaning. Their logic is severely impaired, that they're talking in ways that seem very weird. So in mild forms, the person's talking and they're just jumping from topic to topic. When you listen to somebody with schizophrenia talking, they're just talking about one thing, goes to the next, and it's just like, what is going on with this person? In severe cases, the person begins to jumble words and phrases together. When they're jumbling these things together in kind of a nonsense way, that's called a word salad. And then sometimes they just begin creating artificial words. So those are neologisms. They're just making words up. So someone that with schizophrenia, that has a severe case, when they're talking, you definitely realize that something is wrong with that individual. Another major disturbance is in thoughts. So one of the things that's marked in schizophrenia is delusion. So these are faulty thinking in people. And there's different kinds of delusions. One kind of delusion is a delusion of persecution. So they believe people are out to get them. They're thinking people are plotting against them. They may be thinking even aliens are coming to infect their mind. Another kind of delusion is delusions of grandeur. So they think they're more important and they really are. They may feel like they're God or something like that. And then the last kind of delusion is a delusion of reference. And so unrelated things or events are given some kind of special significance. So maybe they're reading the paper and they say, oh, there's all these words I need to mark in there because somebody's giving me a message. Or the toaster's making some kind of weird sound and oh, there's weird sounds coming out of the toaster. Somebody's beaming me a message here. And so those are delusions of reference. Another major disturbance is in emotion. Sometimes their emotions can be overly exaggerated, or sometimes they can be completely flat, where basically the person is just kind of there, but they're not reacting to anything, they're not doing anything, they have a very flat affect. One common syndrome in one area of the world is called the Jerusalem syndrome. Every year there's dozens of tourists that go to Jerusalem and they become overwhelmed with or obsessed with the significance of Jerusalem, and then they begin to engage in some bizarre deluded behavior. So they might take the linens from the hotel and begin to wear them as robes or believe that they're Jesus or something like that. So here's where if we were in class, I would have you watch this video clip. It's about 6.5 minutes. But when we're done here, I want you to watch that video clip in Canvas on the Jerusalem syndrome. And you're going to see one individual who thinks he's King David. You're going to see another individual who is wearing robes and moved his whole family there. So you're not seeing people necessarily talk like they're completely bizarre. They're looking kind of like normal people, except the guy that's King David, he's all dressed up and everything. But they have these delusions. And so that's something that's common that happens in Jerusalem. So that's an example of an exaggerated emotion. And then lastly, there could be a disturbance in behavior. So we could see some very unusual, exaggerated motions. We can see catalepsy. So in that case, the person doesn't move at all. They're cataleptic. They just are like there staring off into space and not moving or doing anything. Sometimes we might see what's called a waxy flexibility. So that means they're not moving, but if you were to raise their arm, instead of the arm dropping like it would for a normal person, you raise their arm and then it just stays there where you raised it. Now, there's ways to classify schizophrenia. One way is to begin to categorize it. So one category would be paranoid schizophrenia. This is where the person has these delusions and hallucinations. Okay, they're hearing voices, they're feeling they're being persecuted or things like that. Catatonic schizophrenia is when we're talking about their motor disturbances. So either they're in that state where they just don't move, they've just completely withdrawn from reality and they're not talking or moving or doing anything, or they're on the other end where they're completely wild in their activity. They're giving that weird speech, or they might even be giving echo speech where they just start repeating everything people are saying. There's disorganized schizophrenia where we have the incoherent speech and then the emotions are either flat or exaggerated and we have that withdrawal. We have the undifferentiated schizophrenia, which is we are diagnosing the person as having schizophrenia, that they're out of touch with reality, but it doesn't quite fit the other categories. And then residual schizophrenia, where a person has suffered from schizophrenia, but they no longer meet the full criteria, but they're still showing some symptoms. Now, critics have said that this doesn't differentiate in the terms of prognosis. Is the person going to get better or not, or what's caused it, or how are we going to treat it? So some researchers have proposed an alternate classification system. And so they classify schizophrenia into two categories: positive schizophrenia and negative schizophrenia. Positive symptoms are more common when schizophrenia develops rapidly. And so positive schizophrenia is associated with better prognosis for recovery and treatment. Negative schizophrenia symptoms are more often found in a slow developing schizophrenia. Explanations of schizophrenia: one is biological, that there's a genetic predisposition, and then if certain things happen, that person can develop schizophrenia. Disruptions in the neurotransmitters, the brain, abnormalities. Things that may contribute to schizophrenia are prenatal viral infections, birth complications that affect the brain, immune responses from the body, maternal malnutrition during pregnancy, or advanced paternal age. There seems to be a correlation in some cases where the father is very, very old. When we look at scans of the brain, we can see a normal brain has certain areas that are lit up. A person with schizophrenia has certain areas, like in the occipital lobe, that are red. That's very lit up, and of course that would be associated with seeing things that aren't there, so hallucinations. People who are depressed are showing less lighting up in certain areas of the brain. So we do see different levels of activity with people suffering from schizophrenia and also from people suffering from mood disorders. If we give people amphetamines, that increases the amount of dopamine in their system, and that can worsen the symptoms of schizophrenia. Or in people who are predisposed, amphetamines can then bring out or cause that schizophrenia. So that's something where a person has a genetic predisposition, they might have lived their whole life and never had schizophrenia, but then they take amphetamines and then that pushes them over the edge. Drugs that reduce dopamine tend to reduce the symptoms of schizophrenia. There's also the diathesis stress model. That says stress is what plays a very essential role in triggering schizophrenia in people who already have an inherited predisposition to the disease. Disturbed family communication is something that we find that there might be unintelligible speech going on in the family, or fragmented communication, or they have parents that send contradictory messages. So one time they're saying this, one time they're saying that, and the person gets very confused. So we have these severely contradictory messages to the children. So there's different things that can bring on schizophrenia, and generally we're looking at a combination of things. There's not just one thing, but there's combinations, and when those combinations occur in certain individuals, and that is bringing about the schizophrenia. There's been movies done on famous people who have suffered from schizophrenia, like John Nash, who was Nobel Prize winner, and Brian Wilson, who was a member of the Beach Boys, very famous band back in my day. And again, the movies create misinformation. Both of these individuals were geniuses in their particular area, but they developed schizophrenia and began to have some serious problems, but they got treatment. And the movies portrayed that, okay, they got treatment and they're taking these drugs now and they have to take these drugs for the rest of their life. And that's not true. In both cases, both of those individuals got treatment, took drugs for a while, but then got off of those drugs. And so they learned that, yes, I'm going to hear voices in my head, but I don't have to pay attention to them. They learned that, okay, this is the way that things are going to be, and this is how I'm going to cope with that. Their families learned that, okay, here's the new normal. Here's what they're going to experience, and we're not going to freak out. We're just going to support them. So they're able to continue on with their lives. And in fact, Brian Wilson is still playing music today in concerts with the Beach Boys, who are pretty much older now, but they still go out and tour. Okay, so a group of psychotic disorders characterized by general loss of contact with reality. Obviously, that's what we've just been talking about, is schizophrenia. And then biological reasons and psychological factors that contribute to schizophrenia. Biological reasons are obviously just genetics, brain abnormalities, neurotransmitter issues. Psychological problems are stress models and disturbed family communication. Another set of orders, now this set isn't in chapter 13 in your book, it's actually in chapter 5, but it is a kind of disorder, so I'm going to talk about it here, and this is where I'm going to test on it. So that's substance-related disorders. So we have substance abuse and substance dependence. So we want to establish the difference between abuse and dependence. And so we're talking about mood or behavior altering drugs. So that could be alcohol or other drugs. So substance abuse interferes with the person's ability to interact socially or at the job. Substance dependence causes physical reactions such as tolerance and withdrawal. So symptoms of substance abuse, the person fails to meet their obligations. They're too drunk to go to work, for instance. They have repeated use of the drug or alcohol in situations where it becomes physically dangerous to do so. They continue to use despite the problems like missing work or getting a DUI, but they continue to do this and use the substance. And so they may have repeated legal problems because of that, either DUIs, driving under the influence, or involved in the illegal buying and selling of drugs. Substance dependence means that they experience several things. One is tolerance. So a person who's been using alcohol for a long time, for instance, maybe initially one drink would get them buzzed, but now they need 3 drinks to get them buzzed, to get that same situation. They begin to have a tolerance to the substance. That's very true of many drugs, where the first time the person uses it, they get this incredible high, but after that, they don't get that same feeling. So there's something called chasing the high. So they tend to begin using more and more of it to try to get to that point that they felt before. Another physical symptom is withdrawal. If they stop using the drug, they begin to get sick and sweat and shake and have withdrawal symptoms. And so their body reacts in a very disturbing way. And they either have to take the drug again to diminish these symptoms, or they have to go through this terrible withdrawal until they can be done with the substance in their system. The substance is taken for a longer time or a greater amount than what's intended. So sometimes people, for instance, have back pain. They get a prescription to help them with the back pain. Well, now the back pain's gone, but they're still taking the drug after that, or now they're taking greater amounts to try to get that high or a greater high. They begin to have a lack of desire to control their drug use or their alcohol use. The things that they used to be involved in become less and less. So most of their time then becomes related to obtaining this drug or alcohol and using it. And so they're not so much interested in their job, their friends, their activities. They want to, all they're thinking about is, where can I get more of this drug and how am I going to get it, and then using it. And they continue using that despite knowing that psychological or physical problems that they have are getting worse. So we want to know the distinction between substance abuse and substance dependence. Now, often people who have depression or anxiety or other kinds of disorders where they're feeling that distress, one way to try to escape that distress is through drugs or alcohol. And so people with these substance-related disorders often suffer from another psychological disorder like depression or anxiety or something like that. So that's a condition known as comorbidity. So comorbidity is having more than one disorder at the same time. It's common with substance-related disorders, but it could be other disorders. A person could have an anxiety disorder and a depressive disorder. That's comorbidity. So having more than one disorder. The next class of disorders are dissociative disorders. So we have disassociation. Okay, that's a splitting apart of significant aspects of the experience from our memory or our conscious. So often there's some traumatic event that's happened in that person's life that's causing a great deal of anxiety, and they're trying mentally to escape from that anxiety. And so there's some kinds of dissociative disorders. One is dissociative amnesia. They forget about what happened. Okay. I know we have this picture of this kid looking at this car all mangled up. Maybe he was in that car when it had an accident and maybe somebody was killed. And now he's looking at the car and says, I don't ever remember being in the accident. And he doesn't remember the 3 weeks leading up to that, possibly. Okay. Sometimes people might disassociate the whole life that they've had up to that point. So that's one kind of escape. Another is a dissociative fugue. And so the mind kind of shuts off for a while. So a person might be sitting at home, watching TV, and then the next thing they know, they're standing on a street corner 2 blocks away. And they're going, well, how did I get here? So their mind went into this fugue. Another is depersonalization disorder. So they're losing some sense of reality and kind of feeling estranged from themselves. They're feeling that they're kind of not themselves, but being pulled away from that self. And then lastly is dissociative identity disorder. Sometimes in order to deal with something, somebody might, we talked before about reverting to an earlier stage like regression, but that person may want to escape this painful situation and go back to, okay, when I was a child, things were good, and kind of take on that identity of the child and that kind of way of looking at things. And then at another point, they realize, okay, I've got to survive. I've got to have dinner and get things done. So they take on this identity of an adult at that point. And so this is the multiple personality disorder. Schizophrenia is not multiple personalities. Multiple personalities are a dissociative disorder, and dissociative identity disorder is the multiple personality disorder. And so those different personalities are called alters. And so it begins not suddenly, but sometimes, as I said, a person is trying to deal with the trauma, and so they go back to some other personality aspect that helps them to cope. And so then these personalities develop. So a person might have one alter, that's their way of retreating and escaping, and then their self is dealing in the real life. Or some people develop multiple alters and they have different personalities to deal with different aspects of their problems or their things in life. So that's probably the best known dissociative disorders, the dissociative personality disorder or multiple personality disorders. Another class of disorders are personality disorders, and we have 2 basic personality disorders. And so people are having some kind of impairment in their ability to function in society. One could be common for people your age. One is not common and definitely wouldn't want to come in contact. So we have antisocial personality disorder and borderline personality disorder. The first is antisocial personality disorder. Okay, these people are often called a sociopath or a psychopath. They have profound disregard for other people, and these are the people that can be dangerous, and these are the people that we find could be murderers. They're very egocentric. They think of themselves and their own self-importance, and so they have a lack of conscience. They don't feel guilty about hurting other people. They engage often in impulsive behavior, and it's common for somebody with an antisocial personality disorder to have this superficial charm, that they look like somebody who you might be attracted to. They know how to play on your weaknesses and how to take advantage of you. So they seem like maybe they want to be helping you, but they have their own agenda and they're really working toward hurting you. People with other mood disorders or with other psychological disorders like anxiety or mood disorders or schizophrenia feel some kind of personal distress. Somebody with an antisocial personality disorder doesn't feel that distress. And so they're capable of bringing considerable harm and suffering to others. Okay, they have very good insight into the needs and weaknesses of other people. Antisocial personality disorder is very highly correlated with abusive parenting styles and inappropriate modeling. So there might be some biological components, a genetic predisposition or abnormal brain functioning, but there are also psychological components, as I've said, a high correlation to abusive parenting or possibly inappropriate modeling. So antisocial does not mean that person doesn't want to be part of society. It doesn't mean that they don't get along with others or that they withdraw. Okay, antisocial means that they're thinking of themselves and they can use that charm and that knowledge of other people to get what they want from them. And so they can be very dangerous. Another kind of personality disorder is borderline personality disorder. The core features of borderline personality disorder are impulsivity and instability of mood. That kind of correlates to bipolar, where they're up or down. And then an instability in their relationships in their life and in their self-image. So they're very subject to chronic feelings of depression and emptiness, and they have an intense fear of abandonment. And they may engage in destructive, impulsive behaviors. And so cutting, when a person cuts themselves, that's an indication, and they would be diagnosed with borderline personality disorder. Now, they may have other disorders, but if they're cutting themselves, they would definitely be diagnosed with borderline personality disorder. They might engage in these destructive behaviors like sexual promiscuity or excessive drinking or gambling or eating sprees. They might attempt suicide. They look at people and themselves in absolute terms, that you're either perfect or you're worthless. And they look at themselves that way. At times they feel like they're perfect and better than everybody else. And at times they feel like they're worthless and they're no good. So it becomes hard to have a relationship with somebody when one day they're treating you like a god and you can do no harm, and then the next day they're saying you're a bag of trash and you're just absolutely worthless. So it becomes difficult for them to maintain relationships. However, people with borderline personality disorder can get treatment, and they can get treatment and marry and have families and children and live very happy, productive lives. They frequently have a childhood history of neglect or emotional or physical deprivation or some kind of sexual or emotional abuse. So that's generally what brings on the borderline personality disorder. All right, people with substance-related disorders also commonly suffer from other psychological disorders. Somebody unmute your mic and tell me, what is that?
Comorbidity.
Yes, comorbidity. A serial killer would likely be diagnosed as having what disorder?
Antisocial personality.
Yes, very good. Antisocial personality disorder. Okay, so we have some major classes of disorders. We have the anxiety disorders as a major class, and under that we have phobias, OCD, and PTSD. We have mood disorders, where we have major depressive disorder and bipolar disorder. Schizophrenia, we have different types of schizophrenia. Substance-related disorders are substance abuse and substance dependence. The dissociative disorders like amnesia, fugue, dissociative identity disorders. And then we have the personality disorders. We have antisocial personality disorder and borderline personality disorder. So two things about a test. One is there's going to be a number of questions where I'm going to say the person is doing this particular thing or feeling this particular way, and then ask you which disorder most likely they're suffering from. So you're going to have to identify that. In a free response question, I may ask for you to give some of the disorders, like not every single one under a category, but for each of the categories, anxiety, mood, substance, dissociative, and personality, for those 5, so not including schizophrenia, I may ask you to give one particular type of disorder under that category and then give an example of how a person is behaving. So it has to be something specific, not something general, okay? Not just, oh, they're feeling bad, but something like, you know, they're suffering from depression, so they used to like to play basketball, and now they don't like to play basketball anymore, and they sit at home and don't see their friends. So giving something specific. Now, we're looking at how gender affects abnormal behavior. The rate of depression for women is 2 to 3 times the rate for men. So now there's biological influences that may account for that, like hormones, biochemistry, genetic predisposition, psychological processes, the ruminative processes, how women think about things differently than how men think about things. There's how our culture affects that. So in our society, the social factors that work against women are more likely to suffer greater poverty than men. They're more likely to have work-life conflicts than men. They're more likely to suffer from unhappy marriages than the men in an unhappy marriage. They're more likely to be victims of sexual and physical abuse. And so these things, these cultural things, may have an effect. Now also, men are socialized to suppress their emotions, okay, and then to show their distress in other ways. So they're culturally made to show their distress in aggression or doing things that are reckless or involving substance abuse. So we may really be underestimating the rate of depression in men because they're culturalized to express their distress differently. When we look across cultures, there's some forms of distress that we see in all cultures, and then there are some that are different, but there's a few things that are the same in all cultures. And then you can look at the slide if you have it in front of you, or if, you can get it off the website, but I'm not going to go through each of these. But we see in different cultures that people are culturalized to express their distress in certain ways within that culture. So in one culture, it may be running amok and being aggressive and trying to injure others. In other cultures, it may be a tiredness of the brain that relates to school. In our Western nations, anorexia is something common to the Western nations, but not to the other nations. And so people are displaying their distress through eating disorders. So different countries have different ways where people learn in their culture ways that they're going to express their distress in some way that's acceptable in that culture. All right, so that concludes our section on psychological disorders. And so now we only have one more chapter to go, and then we'll be finished. So remember, I want you to go watch that little video on the Jerusalem syndrome, so you get an example, you get to see that in action and see what's going on there. So before we leave today, any questions? Okay, there's a question. I just brought the chat window up. Is there going to be a final after the test on chapters 13 and 15? Yes, there's going to be a final exam, but you don't need to worry about that. Trust me, it's not going to be something that's going to cause you stress. So the final exam, you'll be okay with that. The test on chapters 13 and 15, you want to do well on that. There will be a final exam, but that's something you don't need to worry about. Trust me. So it'll be way different than that other test. All right, then, if there's no other questions, then you guys have a great day, and we'll be back here on Thursday. Bye, guys.